Hey, Sud, welcome back to another episode of Now I Know. I'm Dr. Sam Barry.
And I'm Dr. Sud Koushik. It's great to be back, Sam.
Yeah, and what are we talking about today, Sud?
We're talking about astigmatism, everybody's favorite topic. It's awesome, and it's something we need to address, right? Always address it. I mean, what is astigmatism? You want to tell me?
Yeah, so astigmatism, you talked about the etymology, I think, of cataracts. So I'll talk about the
Yeah.
etymology of astigmatism. I don't know it just off the top of my head, so I had to look it up. And astigmatism really comes from the prefix a, meaning not, and then stigma, meaning a point.
Hmm.
So that means the light entering the eye is not meeting at one point. So our very clearest vision, going back to just how the eye works, is when the light entering the eye is focused by the cornea and the lens, both of which act as kind of, if you think of basic physics or optics, they act like lenses. So spherical lenses are just lenses that have the same strength in every axis or every meridian. So ideally, our cornea and our lens both are spherical. So they're like kind of a baseball or basketball shape. And so if that's the light entering the eye is hitting both of those, the cornea then the lens, and then hitting the retina. If those are all spherical, then we're getting everything at one point. So astigmatism means not at one point. So that means somewhere along that line, light rays are being refracted or being focused a different way so that they don't all land at one point.
Got it. So Sam, I guess what you're telling me though is since the light is not being able to reach one single point, it could really be the cornea, that clear windshield of the eye, or it could also be the lens, which is inside the eye. Either one of those things could be causing the issue to not allow the light to hit the same point, or it could be both of them contributing. Is that correct?
Yep, that's exactly right. Exactly right. So
Got it.
when it comes to, and we'll get to this, we're going to try to break this up again into kind of general overview, educational part, then a part that's more for med students and residents, and then another part that's for kind of fellows and attendings and other surgeons level. So we'll break that up into kind of how we address each one of those for corneal and lenticular or lens-based astigmatism, and how we measure those and kind of how those bear out in terms of measurements, manifest refraction, all that sort of thing. But
Awesome.
just going through the basics again, like you said, it's can be from the cornea, can be from the lens, but all together, our measurement for astigmatism, what most people see is their glasses prescription or their contacts prescription. And so, like we mentioned before on previous episodes, that second number of our prescription, the second number and then the third number. So it might say something like one number plus 1.0 at, or little x for at, 90. So that second part there, the one diopter at 90 or plus one at 90, is going to be the astigmatism measurement. And that's what we call like a manifest refraction or our glasses or contacts prescription.
Okay, so I think based on what you're telling me too, with the glasses prescription or the contact lens prescription, that is addressing the astigmatism. And then you and I, as surgeons, I think probably hear it all the time from patients. If I didn't want to wear glasses or I didn't want to wear contacts, would a laser vision correction also be able to address my astigmatism?
Yeah, I think that's a great point, and that's something I hear all the time, which is people say, I have astigmatism, I can't have any correction. I can't have LASIK, I can't have SMILE, I can't have that corrected. And then that's a, preconceived notion that's actually generally not true. We can actually usually treat astigmatism with surgery, with glasses, with contact lenses. There's multiple ways to treat it, right? Astigmatism, I think, gets this rap of being some pathology or something that's dangerous or bad. But it's really just a way of describing kind of the way that light enters the eye and is focused. Most of that is at the corneal plane. So we're talking about, a different refractive power, meaning like you and I probably say the same thing. The cornea is shaped sometimes more like a football than like a basketball. So a football has one, if you, follow a football around, it's steep one way. But if you follow it the other way, it's not as steep. So the way that a lens works is when light hits that area, the part that's steeper, gets more focused quickly or more refracted, and the flatter part, doesn't get focused quite so quickly. So you can imagine those light rays are not focused at the same point of the retina, and so our lenses in our glasses can fix that, or our lenses in our contact lenses can fix that, or we can fix it surgically. Whether that's EVO ICL, whether that's IOL surgery for cataracts, what we call toric IOLs, or laser refractive surgery, SMILE or LASIK or PRK.
Awesome. It's great that we have all these different options to address astigmatism and really give patients the best quality vision. I think something that maybe the medical students or residents will hear referred to, and something we can elucidate a little further, is something called with the rule astigmatism and against the rule astigmatism. What are these terms, and I guess how do we break them down and address them?
Yeah, so for the med students and residents, if you want a quick way to remember this, and maybe you do the same thing here, Sud, for with the rule astigmatism, I think I'm just nodding my head, with the rule. And then against the rule is like against and no. So when you look at topography or you look at the axis, we're talking about one steep and one flat, and those are at 90 degrees from one another or orthogonal. One can be at 90 and one can be at 180 or somewhere around that range, And so if we're talking about the steep axis being at 90 is going to be with the rule. So like shaking your head up and down, and then the steep axis being around 180 is against the rule, and getting a little bit into the, nitty gritty there, we kind of say on either side of 180, about 30 degrees would be against the rule. Same thing with 90. So from about 60 to 120 is all with the rule. And then we have what's called oblique astigmatism, which is much more uncommon, but somewhere around like the 45 or 135 axes. So for people who aren't watching, which they should watch on YouTube, it's much more of a visual podcast. And then later we'll talk also about some surgical cases. So everyone should watch on the YouTube. It's better to watch that way. But
definitely. Then you also get to see Sam's face, and he's a great looking guy. So you got to check it out on YouTube.
I just get animated about astigmatism. I think everybody should have as little astigmatism as possible, And I don't know about you, Sud, but like when I talk with patients in clinic and they ask me about astigmatism, I'm like, nobody asked to be born with astigmatism. We all have a certain level. Everybody has a certain level. Whether it impacts the vision enough to require glasses or contacts, that kind of gets into grades or levels of astigmatism. So what I tell people is like on a scale from 1 to 10, your astigmatism is here, So some people who are 1 or 2 won't even wear glasses or contacts. People who are in that middle range typically wear glasses or have surgery or, have some way to address it. And then people who are on the extreme, that's how I also point out things like irregular astigmatism. So things like keratoconus or cornealectasias. And I tell them it's astigmatism. It's just on the extreme and it's irregular. So we address it in a slightly different way. And we'll talk about, I'm sure we'll have future episodes on keratoconus, cornealectasia, things like that.
Yeah. And actually just touching on your point about irregular astigmatism, just for people tuning in. So usually when we say you have astigmatism and it can be addressed by contact lenses or soft contact lenses and glasses, that's a regular type of astigmatism that we're treating with that. And usually if we cannot address the entirety of your vision with glasses or soft contact lenses, then we at least have a suspicion at that point that maybe this is an irregular astigmatism. And then as Sam mentioned, we can use other imaging tests and do other things like over refractions that will really help us figure out the astigmatism and whether it's irregular due to something like keratoconus or lucid marginal degeneration or even just trauma and scarring from a previous injury. So I think that's a great point with the irregular astigmatism. And we do have surgical techniques to even address or minimize irregular astigmatism. So it's an exciting time to be an ophthalmologist and also to be a patient.
It is. Yeah. And that's on the kind of forefront, kind of the cutting edge of treatment of keratoconus and cornealectasias is how do we address that in a way that's best for the patient? Like generally speaking, we don't do LASIK and PRK and SMILE for these patients that have keratoconus or have what we consider to be early signs or form-fruste keratoconus, right? But what are ways that we can help improve their vision with, surgery, with cross-linking, EVO cares? We'll do all that. I think that's a great topic for a future episode for sure.
Definitely.
Yeah. Can you talk to us just briefly about how you talk to patients about contact lenses? So you mentioned soft contact lenses, but I think there's probably a lot of people listening or, tuning in that wear different kinds of contact lenses. So what's the reason that we would wear different kinds and how does that tie into astigmatism?
Definitely. Yeah. So I think contact lenses are a big topic, and just this is one of those categories where I'm just thrilled to have our optometry colleagues along there with us, because they do an excellent job fitting these contact lenses and also going through the different types. And those might be rigid gas permeable lenses or scleral fit lenses, where I have no real experience or expertise in that area. Soft contact lenses, I would say, are what the vast majority of patients are wearing. It can address regular astigmatism with a toric nature. So it can have a little, you might look at a contact lens and see that it has a little straight line or denotion there. And that's actually to help let you know that it is a toric lens, and it's going to have a little weighted positioning so it actually knows where it needs to be on the eye and address the astigmatism. As far as other things like the rigid gas permeable and the scleral fit contact lenses, those are actually excellent options to help address irregular astigmatism, like we had mentioned earlier. And then they actually kind of reshape that corneal plane, that dome. So if there are kind of dips or irregularities in it, you can use one of these things like a rigid gas permeable lens to help restore or kind of create like a new smooth corneal surface that does not have those irregularities in it. And those are definitely more challenging to fit from the provider aspect. It's also, I think, a little more challenging for the patient to get used to. But I think with a little bit of time and training, people can get really good at them, and then it really helps them achieve a wonderful vision that they couldn't get without that lens. In terms of talking, in terms of talking to patients, I feel like I won't speak for you. I feel like I'm not the best at talking about contact lenses. I mean, I think that's why we're both also heavily on the refractive surgeon end of the spectrum, where we're like, oh, let's get you out of those. Let's use something else. But
shout out to our optometry colleagues who are so good with contact lenses. If they want to come on, whoever's listening, I think we've both have some friends that are optometrists that are great at this, and I'd love to have them on so they can teach us a few things about that, because it would be it'd be helpful for me to learn that. Right now, I know what our limits are, and then I say, you're going to go see this excellent person who's going to take care of you and put you in a contact lens. And I try not to overpromise, but I'm like, they're going to do so much better for you than I could do. Like, they're going to do exactly what you need. I think of the keratoconus patient whose best corrected is like, 20/50, 20/60 in glasses. And I'm like, I think you're probably going to get to 20/20 with a contact lens with this good provider. So,
yeah. Exactly. I do the same thing. Yeah. So definite shout out to them. And we definitely need to have some on board and be able to teach us a thing or two.
Yeah. So important to have optometrists. I mean, they're eye doctors just like us. We all have our own specialties, just in the same way that, they rely on us for surgery. We rely on them for basically having huge brains and teaching us things, So managing contact lenses, managing, refractions that are very complex. Prisms. I touched prisms this week. That was tough, but you can still do it. But they do it a whole lot better than us.
Definitely.
Yeah.
Well, what about, I was going to ask, in terms of refractive surgery, like the whole spectrum we just talked about, LASIK, SMILE, PRK, and then also EVO ICL, and also doing IOL surgery after removing cataracts. Do you have a threshold that you're looking at in terms of how much astigmatism you would treat? Is there a point that you're like, okay, this is too small of an amount of astigmatism, I don't really need to address it, or is everything free game and you want to just remove everything?
Yeah, I think it depends on the context, right? I mean, there's different levels that we treat for different procedures and different amounts that are kind of tolerable based on certain parameters. In general, I think if you're a fellow or a resident, or another eye surgeon like us, less astigmatism is always better. I think a successful outcome, what we're aiming for, and how we measure our outcomes, how we track our outcomes, is half a diopter or less. I think that's a great point to aim for. Now, that doesn't mean that if somebody has more than half a diopter, you have to address it, right? Sometimes our predictive, calculators will say there's a diopter and a half of width the rule, but we know that that's measuring the anterior cornea. It's not factoring in the posterior corneal astigmatism. Not to get too in the weeds, but sometimes you do nothing, and that's the right thing, right? And then other times it'll say there's 0.5 of a diopter. There's 0.5 or 0.4 of against the rule at the time of cataract surgery, and we know we need to treat that, because if we don't treat that, we're going to end up with 1.5 diopters against the rule astigmatism, if we don't put that toric lens in. So to answer your question kind of in a roundabout way, is to say there's different thresholds for each procedure we do. And that's kind of where it comes into the training aspect and the working with your mentors to figure out how to get the patient the best outcome. But breaking it down like one by one, I'd say laser vision correction. So LASIK, SMILE, PRK, that's really based on the manifest refraction, right? So we're treating based on your glasses prescription, your contacts prescription, and we have parameters in our laser that we plug in there and we just treat that amount, right? So that's kind of a no-brainer. We're just minimizing that astigmatism as best we can by treating the cornea, okay? Same thing with EVO, really. Implantable contact lens is based on your refraction. And so take that refraction, we have a certain amount of astigmatism built into the lens, and then we implant it at the eye and we put it at a certain axis. And actually we have a good video of it coming up for the people who are watching, and we'll describe it for listeners too, just so they don't feel excluded. But basically the toric ICL, the EVO implantable contact lens, starts at about a diopter of astigmatism correction and goes up to about 4, right? So I'd say for me, and I'd love your input in nomogram too, I start at about a diopter on the manifest refraction. That's when I start considering it and talking about it with patients at that 0.75 to 1.25. I start talking with them about risks and benefits, toric versus spherical. Toric, there's the possibility of rotation, has to be oriented just right. Spherical, we might end up with some residual astigmatism. And as you and I know, that impacts the uncorrected visual acuity. So there's kind of the risks and benefits or pros and cons at that level. Now, 2, 3, 4 diopters, that's a no-brainer. We just treat that.
Yeah, definitely. I think that was a great comprehensive overview of all the different options and when to consider it. I definitely counsel patients who have beginning at about 0.75 diopters of astigmatism with the benefits of toric ICL versus non-toric, and just so that they understand that distinction. And I think one thing, just kind of changing gears here for a second, is I had a early resident, I should say, just pretty much just starting ophthalmology residency, just completed their intern year in medicine shadowing, and they were watching us in the pre-op area before bringing patients back to the OR, and we were marking some patients in the pre-op bay, and they were asking, why are you marking them here? Can't you just go ahead and start things out in the surgery? You're going to see the eye the same way, when you're back there underneath the microscope. So I think that's a great point too when you're talking about astigmatism and marking. So can you tell us why we are marking those patients in the pre-op area and how we're marking them, I guess?
Yeah, absolutely. Absolutely. So let's take a step back for just a second. I wanted to briefly, talk about manifest refraction and what we do for our evals for corneal refractive surgery and EVO ICL. Definitely. So I think you and I both, trust what the patient is wearing and trust the technician or optometrist refraction, but we always double check it because that's the most important thing. And sometimes we'll do what's called a cycloplegic refraction as well. And a cycloplegic refraction is where we dilate the eyes, which relaxes accommodation. So how you can feel your eye focusing when you're looking up close, like you can feel that? That's what accommodation is. And so we put drops in so that you can't do that. So for our 20-year-old patients, I tell them it's like hitting fast forward on the, aging and being like 50 years old. So you can't see your phone for a couple hours without reading glasses, but that wears off after a little bit. But when we do that in order to fine tune the spherical equivalent or the sphere. And what I don't do, and I'd love your input too, is I don't change the sill. I don't change the axis when I do that. And that's because the refractive astigmatism, our measurement of astigmatism, is based also on the pupil, right? So it's based on pupil size, location. So when we dilate, the pupil also expands. And so the refractive, error from the cylinder and the axis can change. But that's not how we live our lives. We live our lives with normal sized pupils. And so that's an important point for, refractive surgeons, residents out there, is that when you do a cycloplegic, you're doing it purely to relax accommodation and get the right spherical error.
Yeah, I totally agree with that. I do not mess with the sill or the axis. Once the patient is cyclopleged, I am really just fine tuning sphere. Actually, on that point too, since we are talking about cycloplegic refractions in the context of refractive surgery, I do like to perform what's called a duochrome test as well. Do you do that? And we can talk about that maybe for like a brief 30 seconds.
Yeah, please. Duochrome tests are fantastic. Please talk to us about it. I don't do it
Yeah.
routinely, but if somebody has a significant difference, I'll do it like
Mhm.
between what they're wearing and what we're refracting them at. Yeah.
Yeah. So, I mean, this testing, you might, as a patient, have your doctor put up a set of letters on the screen that have one side background red, one side background green. And what they're actually doing at this point is trying to pick up on the fact that the color and the wavelength of light gets bent differently if it's a shorter wavelength or a longer wavelength, and that's reflected by this test. And it can help fine tune that sphere as well. So when patients are already cyclopleged, I do like to perform this test too, just to see kind of where I'm at for that sphere portion of the prescription. So once again, that first number in that whole manifest refraction, I'm trying to adjust that, and it can also work on colorblind individuals too. So
You beat me to it.
you
I was
know,
going to say the same thing. It's so
yeah,
cool that works. And if you're colorblind, if you're red-green
yeah,
colorblind or any kind of colorblind, it still works because it works through chromatic aberration, right? It works through
exactly.
the wavelength of red and green light being different.
Exactly.
Yep.
Yeah. So it's a really cool thing, and probably something that could be relevant to residents as well as these kind of things are tested.
Yeah, I was going to say for residents, if they just want the short version of this, just remember RAM gap, right? Is that how you think about it for
I
the,
love it. Yeah. RAM
yeah.
gap all the time.
Red add minus, green add plus. That's
Yeah.
what Dr. Koushik is doing in clinic all the time. Just
All the
RAM
time.
gap, right in the head, running through there.
That's it. Makes it hard for me to remember anything else because I just keep thinking RAM gap, RAM gap.
Yep. Isn't there one for contact lenses as well? There is for like steepness
Yeah.
and yeah.
Yep.
Yeah.
I think it's Sam Fap.
Yep. Steep add minus and flat add plus, right?
Yeah, I believe that's right. Yeah.
So
I
for
use
our
that
ODs
less
out
commonly.
there, less common. Yeah. We still remember some things. All right. We
Yeah,
still remember.
Exactly.
Yeah. Getting back to what you were saying and
Yeah.
bringing up about marking the eye, I think that's a great point. There's amazing technology now. We live in such a cool time for eye surgery and for laser refractive surgery, for everything that we do. So historically, what we do is mark the eye wherever you want, typically 0, 180. Some people mark at 92. But we mark with the patient sitting up. And the reason for that is when we lay down, there can be a variable degree of torsion. So torsion just means rotation of the eye. So the 0 and 180 axis when we're upright is how we want to fix their eyes, because there aren't many opportunities that we're laying down looking up at the ceiling that we want to see perfectly clearly. Even so, that rotation that happens with the eye would happen with the lens as well, right? So we're correcting for what we typically live with habitually. So that's how we mark, is with an actual surgical marking pen at 0 and 180. And then we use our Mendez ring or use something else in order to actually get the axis that we're going to orient that lens at, whether it's an ICL or an IOL or for SMILE too, right?
Yeah.
So for kind of increases in like what we can do technologically in the last few years, there's ways that we can take pictures of the eye preoperatively with our measurements. So certain machines can do either iris registration, which means that colored part of our eye, taking a picture of it, and then using the microscope or using some other acquisition system intraoperatively to identify those same irises or irides and orient the lens based on that. So really cool that we can do that with kind of an overlay on our microscope. The second way that we can do it that is also incredible is using, again, the same preoperative picture and then using conj vessel registration. So the white part of our eye has very small red blood vessels, and it can capture those images. It's kind of like a fingerprint of our eye. Both of those are kind of like fingerprints that are unique identifiers. And so then based on that, they can either do, again, an overlay, or even shout out here to Ally, the LensR platform that can do capsulorhexis. So at the time of clear lens exchange or cataract surgery, if we use the Ally femtosecond laser, and we're not sponsored, I just love that platform. Incredible. But it can make marks on the capsule. So it makes these little tags on the capsule, and we can orient the lens specifically right at that capsule. And post-operatively, we can see if there's any rotation of the lens, away from those marks. It eliminates parallax, which is, when you're marking the cornea and looking down to the lens capsule, there can be a little bit, of that parallax that makes us maybe miss the mark a little bit as well. So theoretically, in my head, that's the most accurate way in theory. Now in practice, there's some really, really good studies that show that manual marking is also fantastic, very reliable, and gets us the outcome that we're looking for. So I actually still do the majority of manual marking. I think it's great, and it's had great outcomes. If you track your outcomes, you can see that it's very reliable. But I do like the possibility of doing it through the microscope and through femtosecond lasers.
Yeah, I mean, that's fantastic technology. I right now do all of my markings manually as well. So just these options that are available to fine tune it or possibly just make it a little more efficient for you as a surgeon, I think are always great.
Yeah, I totally agree. So if you want to, we can go ahead to you want to watch a couple videos here? That's my favorite thing to do,
Yeah.
is review
let's
surgical videos. Okay. So we've talked about, let's talk quickly just about cataract surgery. And we talked briefly about astigmatism correction with cataract surgery. Mm-hmm. But what do those lenses look like? What's a patient, to expect when it comes to that? We can talk about cost as well. I mean, that's variable across the country and maybe variable based on, year to year, but just what kind of patients can expect in terms of what insurance covers, what insurance doesn't cover, and maybe why. That's more of a philosophical point, but we can get into that.
Yeah. I mean, definitely, I think in terms of what patients should expect with a lens that can help address their astigmatism is they can expect better vision. They can expect less reliance on their glasses and contacts. We have lenses that come in a variety of different powers that can address how much astigmatism that they have. And once again, this is going back to that topic of regular astigmatism and irregular astigmatism. This really benefits for regular astigmatism, something that's like dependable and reliable, and we know exactly what axis that astigmatism is at. We can really readily treat with toric IOLs. There are other IOL options that can also address astigmatism that may benefit patients who have more of the irregular kind of astigmatism, and these are things like the IC8 IOL, and that IOL kind of works through a pinhole aperture. So you're actually reducing the amount of light rays that are actually entering the eye, and with the hopes of eliminating or blocking out some of these light rays that would be bent irregularly or erratically, and only allowing those light rays that are kind of coming through the center of this pinhole, about 1.36 millimeters in size, only allowing those light rays to go through and reach the retina. So we've had great success using that lens in patients who have conditions like keratoconus, or maybe they've had refractive surgery in the past, like radial keratotomy, and this lens works really well. You do have to caution the patient too, though, that since you are using a pinhole, you are reducing the amount of light that's entering the eye, that they might experience a dimming effect to their vision. There's also the light adjustable lens, which is a fantastic lens that I think Sam and I both enjoy, and that can also address astigmatism. And you're kind of addressing it in the post-operative period at that point by doing those light treatments and fine-tuning the prescription for the patient. But these are all great options. I think your surgeon would just have to sit with you and talk to you about which one would work best for you. All of the options I've listed, whether it's a toric IOL, whether it's a IC8 IOL, whether it's a light adjustable IOL, are not covered by insurance. And so these are upgraded lenses that would cost more out of pocket. And as Sam mentioned, it kind of varies place to place, time, over the years it can change and fluctuate. So this becomes a little more challenging. I kind of wish we could just say, hey, we're going to put in the best lens for you, address all your problems and be done with it. But that's not the reality, unfortunately.
That's such a good recap there. I mean, from the toric, which just means, astigmatism correcting lens, to the IC8 or Apthera lens, the pinhole lens, to the light adjustable lens. That's a perfect recap. So thanks for going through all those. You're right. I kind of break it down. When I talk to patients, I try to just be kind of straightforward and open about the cost of these lenses. And I tell them, based on, what I'm seeing from your exam and your history and what I think you would benefit from the most, is this lens. And sometimes it's a basic monofocal lens. It doesn't have any extra cost. It's what insurance covers. Oftentimes it's that, actually. But depending on a patient's visual needs and what they're coming in with in terms of astigmatism, like we talked about, nobody asked to be born with 8 diopters, 9 diopters of astigmatism, but it happens. Yeah. And to get the very best vision afterwards, especially uncorrected vision, we have great technology now that, again, just like Sud, I wish it was all covered by insurance, because it'd be a no-brainer. The discussion would be so much easier. But I tell them, this is what I'd recommend. And then if we don't do it, if we go with what insurance covers for cataract surgery, you'll either need, A, B, C. You might need contact lenses. You might need, specialty contact lenses like we talked about before. So I kind of go over what the options are from what I recommend to if insurance covers a certain thing, the monofocal lens, what can you expect afterwards?
Yeah, I think that's perfect. I mean, ultimately, just setting expectations for the patient so that they have a good understanding of what their lifestyle will be like after surgery, whether they're still going to need glasses or contacts or special contacts and things like that. Once they have that understanding, they can really make the best decision for themselves at that point. Yeah.
Yep. And just briefly for, again, other surgeons or residents and fellows, when it comes to multifocality, multifocal lenses or EDOF, extended depth of focus lenses, you have to be great at managing astigmatism in order to use those lenses, because you could nail the outcome from a spherical equivalent perspective, but if they have a diopter or 2 diopters of cylinder remaining of astigmatism, they're not going to benefit from the multifocal. So all of our multifocals come in toric or astigmatism correcting, amounts. So we have to be comfortable using those both in the monofocal and multifocal realm.
Yeah, definitely. And one thing also we could just briefly mention is even at the time of cataract surgery, if you have a game plan to address the patient's astigmatism, and after cataract surgery, they are left with some astigmatism or even some sphere, whether that's hyperopia or myopia, provided that the cornea is still nice and healthy and that they don't have any other issues, you could still always consider and discuss with the patient about doing a laser vision correction at that point to address any residual refractive error. So it doesn't always end with cataract surgery, although I think sometimes Sam and I wish it would, but there's still options available afterwards that we can use to address any leftover prescription that the patient has.
That dovetails so nicely into our videos. So let's talk about when we correct astigmatism, or even let's back up to glasses and contacts. There's that third number in our prescription, there's a certain axis, which means it has to point a certain direction inside the eye, right? So when we do surgery, we orient the lens, whether that's an EVO ICL or an IOL, at that specific axis, like we were talking about, marking, getting that axis, and putting it in there. With Dr. Koushik, it always stays at that axis. For me, sometimes it rotates, and that just happens because our eye, they're not all the same size. That's what I tell people. Our lenses physically are all the same size, but our eyes are not all the same size. So it's not a one size fits all. And sometimes that lens can move a little bit just if there's extra room or, if our eye is just designed a certain way. So those lenses that we put at the right axis, again, assuming we put it at the right axis, occasionally you could put it at the wrong axis. We try our very best to avoid that. That's part of our surgical timeout and part of our planning, right? But let's say you put it in at the right axis and it rotates, then we have to figure out how to address that, right? So what are the options when it comes to addressing that? You mentioned laser vision correction is a possibility as well, but for IOLs and ICLs, depending on the amount of astigmatism and how much is induced, how much rotation, a lot of times what we have to do is go in and rotate the lens, right?
Exactly. Yeah. So that's, I think, an important part of your pre-op discussion and surgical consent about risks and benefits is also informing the patient that there is a chance that this ICL or this IOL can rotate. And there's also a chance that we need to have another surgery to go ahead and re-rotate it. With something like the EVO ICL, it is possible that it rotates and you do have a different size available for you. So you have that discussion with the patient and do the math and figure out and see if maybe increasing the size of this EVO ICL would be a good option to help prevent the rotation. So that is one option as well with the EVO ICL is switch sizing, but you could certainly try and just re-rotate it. And then for IOLs, it's kind of same thing. You can go back in and re-rotate it, and typically I would say, I'll only speak for myself here. Sam can always jump in, but I feel like for that, I like to do that a little bit, or as soon as possible, I guess I should say. As we know, that posterior capsule of where this IOL is sitting can start getting adherent to the haptics or the arms of this IOL, and the longer you wait, it just kind of makes it a little more challenging to free those haptics up and move them. So it almost develops a memory of sorts, and you want to kind of get in there and kind of rotate it before it develops that memory too quickly. Yeah.
I totally agree. And this is really getting into the details and surgical technique. But have you ever done this or seen this done where if you have an IOL rotation for a toric IOL, if you want to, there's no, like you commented on ICL, that was a great point. There's different sizing for ICLs. There's different kind of diameters. But for IOLs, there's no different,
Yeah.
they're all about 12, 13 millimeters across. So
Yes.
have you ever done a reverse kind of optic capture? Does that help with stability where you bring the optic up out of the capsular bag but leave the haptics in there? Is there any thought that, I know some people talk about that, decreasing the risk of further rotation?
Yeah, I mean, I think that's a great question. I personally have not done a reverse optic capture on a toric IOL, so I can't really speak firsthand to
Same.
how beneficial it is. But yes, I have heard that from other people, and maybe it's something that if I have this scenario play out again in the future, I could entertain. But no, I haven't done it already. No.
Yeah. So we'll update the listeners in the future. If one of us does it, we'll have to talk about it because it'll be an interesting case. Yeah. Speaking of interesting cases, I'm going to show two. Okay.
Yes.
The first one is just so people know what we're talking about conceptually. We've been talking about these, but without any images. It's so much easier to just see an ICL surgery, an EVO implantable contact lens surgery, see a toric mark, see what we're aligning, and this is an awesome case of a patient that has 4 diopters of SIL. So this is kind of the max that we can correct with EVO, and it's super cool. The second case is an IOL, and we'll talk more about that in just a second, but it's post-YAG. So that's a very interesting one. How's the screen look there?
I can see your screen. It looks good. Okay, perfect. I am seeing the video now.
Awesome. So feel free to jump in. I just wanted to have for our surgeons out there loading of the ICL. This is the Lioli injector. I've really enjoyed using this injector. I'm a huge, huge fan of this. This is just super easy to load. We're going in with just the really blunt foam tip, and just putting it right in there, viscoelastic, close up the cartridge, good to go. Is that what you're using too?
Yep, that's my favorite to use as well. And just as Sam showed, it's just very quick, very easy. I think a lot of surgeons beginning, they start having apprehension about how do I load the ICL and the time it takes, but you just crushed it right there, and that's why I like it.
Yeah, it's Sam proof. So yeah, it's very, very easy to do.
I like your incisions there too.
Oh, thanks. Yeah, is that where you do them?
I kind of do them slightly differently, like a different angle, but the positioning more or less is the same. Yeah.
This is a 2.7 or 2.75, so I go a little bit wider to get it 3. Right, and here's the toric ICL going in. I joke with patients that loading is the hardest part of the surgery. So once I do that and we haven't even started yet, I'm like, all right, hard part's over. We're good.
Yeah.
Because the rest of this is pretty routine for us. Going in, we're tucking the haptic foot plates now. The first one actually went in just with injection. Then I put a little visco on top and dunked those last ones in. But what about you, Sud? Is this kind of similar to what you use for your this is your technique? Oh yeah, there we go.
This is very similar. As you mentioned, one of the haptics had already gone underneath the iris, and kind of like when you put a Malyugin in and you've already got some of those rings touching the iris. It's such a great feeling when you're putting the ICL in and like maybe sometimes even both the haptics, like leading haptics slide underneath the iris. It's great. Yeah.
Yep. So right here at the end, you saw me rotate the lens a little bit, but here, I think we're going to pause it for just a second, but you'll see at where my mouse is, there's some marks that are aligned with the marks on the conj and cornea, and that's the toric marks right there. So are we seeing it right? Oh, sorry, right there.
Yeah, right there. Yep.
Perfect. Awesome. Well, that's our first beautiful case. Any other comments just about toric ICLs? I mean, we touched on sizing.
Yeah.
Sizing is very important. Vault. We can talk about that day in and day out.
What do you discuss with patients as a percentage risk, I guess, of having it rotate? I typically tell patients based on stuff that I've read in the literature and what I've seen firsthand is maybe roughly about a 2% risk of rotation of an ICL. I don't know if that's similar to what you quote.
Yeah. I mean, I tell them that I don't give them an exact number, to tell you the truth. Okay. I tell them it's uncommon, but if it happens, we can either re-rotate the same one, or we can, like you said, exchange it for a different size based on the calculations. Yep.
Excellent.
So, yeah. And remind us, are your ICLs that you have inside the eyes, those are torics or non-torics?
Yes. Yeah. I have toric ICLs in both my right and left eyes. Yeah.
Nice. What
Yeah.
diopter? If it's not too personal, what
No,
diopters
no,
of
it's
SIL?
not. Yeah, so I have a minus 8 with a minus 1.5. Or sorry,
Okay.
a minus 8 with a plus 1.5 in the
Uh-huh.
right eye, and then a minus 8.5 with a plus 1.5 in the left eye.
Nice. Oh, we didn't. One thing
Yeah.
we didn't touch on, which is because it's not controversial, but it's a point of personal preference, is how you write cylinder notation, how you write astigmatism rotation. You can write in
Yeah.
plus or minus, and I think both are equally fine. What do you think?
Yeah.
That's the only right
Yeah,
answer.
I think. Yeah, exactly. We don't want to start any turf wars here
Yeah.
or feuds, but I think both are totally acceptable. I think historically, ophthalmologists use the plus notation and optometrists use the minus notation. But as long as you understand what's going on and how to convert or flip between the two, I don't think there's any issue using either one.
I've had some patients that, I'm sure you've had this too, that have a printout of a prescription from us, and they're like, why does this look different than my old one? Why am I now
Yeah.
a -8 +2 when before I was like a -6 -2? So I've had to kind
it's
of
definitely
walk people through that, and I have a good website that shows them how to convert. And I'm like, just
Nice.
watch this. Yeah.
Yeah. No, that's excellent. Yeah.
So speaking of that, patients that are very involved in their care, I love that. I mean, I think it's great. It helps us out to become kind of push the envelope in terms of what we can do and what we can offer. This next patient that we're looking at is about 55, 60 years old, and has a ton of SIL, about 8 diopters of SIL. And it's regular. He's had this his whole life. He's always known about it. He's been followed for keratoconus, and it's not keratoconus. It's not an ectasia. It's just a perfect bow tie, 8 diopters of SIL. Man. So it came time for cataract surgery, and I was referred him. I'll get to that point, but I assume what this conversation went like, because I would say this, is, boy, I'm happy you have cataracts, because we can get toric lenses in there and knock down that SIL so much from what you have. I would talk to him about 8 diopters is more than we can correct, even with an IOL alone. So there's options of, up to 6.5 diopters roughly, right, of what we can correct with IOLs. But that would change his life. That's a game changer, to have that amount of reduction. I'd tell him you probably need glasses or contacts still a bit after for that remaining SIL, or we can talk more about going to see Dr. Koushik for that last little touch-up for, either laser refractive surgery or something else that we can do to help with that last little bit of SIL. So they were referred to me. He had both eyes done. First eye, beautiful. Second eye, beautiful. But then at some point in the post-op, first month or two, they noticed that he wasn't seeing as well. He noticed things kind of looked slanted. He got a little bit of glasses, and the glasses that I looked at had with the rule SIL in one eye, like we'd expect, and the other eye had oblique SIL. So he had like 3.5 diopters, 4 diopters almost of oblique SIL. So he was referred to me to take a look at that, and he had a YAG, so the posterior capsule was open, and the toric IOL was about 25, 30 degrees off from the intended axis, kind of where it would best suit him. So I'm going to share this video, but what does that make you? I saw a long sigh there.
It makes my heart rate go up, and it makes me nervous, so I want to watch this video.
All right, let me get to, here we go. Are you able to see that now?
Yes. Yeah.
Let me back it up. Yep. So this is for our podcast, episode 3. Now I know we're looking at toric IOL here for that patient we were just talking about. And I'm marking the eye again. This is marking another way with a Mendez ring. And we're looking at we wanted about 86. And you'll see here in a second that it's at about 110, 111. So this is where we're at. Are you able to see that on the screen there, Sud?
Yeah, I could see it.
Yeah. So I marked, I don't know what your preference is. I marked with a surgical marker, and I also did a little paracentesis blade just to put an actual mark on the cornea in case those marks wore off during surgery.
Yeah, no, that's great.
But feel free to jump in. I'm just going to talk through kind of what I did, and you can say you do something totally different. That's fine.
No, I would do exactly what you do.
This is actually a LASIK cannula. I find this really helpful.
Oh, wow. Excellent.
Yeah. So LASIK cannula, you can just grab it. It's autoclave just like the rest of our instruments, and it can help us get into that anterior leaflet. And so here's the 3 dots of the toric for those watching. Again, watch on the YouTube. It's great. But this is again, brand doesn't really matter, but it's an Alcon Acrosoft lens. It matters for us actually because the way that we do this surgery is affected by what type of lens it is. So you're going to see here, initially I feel like I have good dissection of the anterior and posterior leaflets with the visco elastic, but this lens is notorious for having the terminal bulb. So right at the end of the haptic is where it really gets socked in there. Throughout the case, we had a little bit of meiosis. So the pupil was getting smaller. I put in iris hooks so that we could really make sure we're at the right axis. And here, going with more viscoelastic. Again, viscoelastic is your friend. Don't overinflate because the posterior capsule, as you can see there, Sud, is open.
Yeah.
My goal was to keep it the same size, and boy, it stayed the same size, but it gave me some real anxiety during the case. But you'll see the terminal bulb here. Yeah. I kind of dissected out there with the Cybele, and you can see the tip that's just released. So I found I needed to actually release that manually in order to get the IOL to rotate. Here I put another iris hook in so I could see the subincisional part of the IOL to make sure we're on the right axis down there too. Real quick aside, this visco shield, I love this stuff. Retina surgeons use it. It's so they don't have to squirt with BSS all the time. So visco shield for these long cases helps you have good visualization. Here we can see this is our intended axis and we're right there, right? So that's kind of where I left it. I didn't do any aggressive, viscoelastic removal. I just did it manually. And then I put in some triamcinolone. You're going to see here the triamcinolone allows us to stain for vitreous. And it's actually, you can tell the posterior capsule is open because when you put in that triamcinolone, check out how the red reflex changes. So it went back there. You see how it's kind of that whitish, greenish discoloration, right? And then a little bit of myocol there as well. But that was the color before.
That is...
And the color you saw, the color after was quite different. So definitely posterior capsule was open. And I think some probably went around the zonules as well. So this patient, even the next day, he was super happy because that oblique sill makes everything feel like it's kind of tilting, like the world is kind of falling. So just resolving that alone, he found very helpful. And now he's a couple days out and he's saying it's, as good as his other eye. It's fluctuating because it's early in the post-op course, but super thrilled already.
That is fantastic. That is a great video to see and kind of walk through. I think for the average person who's watching, they don't have an appreciation possibly of just how complicated that is to do and how easy Sam made it look. So I think that's, it's just great to see. And then even using other things like how you use the iris hook to just really make sure you have good visualization, a toric IOL, and even the steps to kind of clear up that adhesion between the capsule and the IOL. I know you use that LASIK cannula. Some people like to use even the smile dissector. That works pretty well. There's also another instrument called the Kady, Kady, and it kind of looks like a very flat butter knife. It's not sharp at the end, but it's got like a wedge type shape and it's very smooth at kind of lifting up that capsule. So that's another great instrument to try and separate that. But yeah, visco is definitely your friend and you made that look easy. So I'm glad that this patient went to see you.
The other thing I should mention, like you said earlier, the earlier you can do this, the better, right? So he was about 3 or 4 months out. Obviously, ideally, you'd prefer it not yagged, right? That'd be nice.
Definitely.
So whenever I have patients that are like that, we try to avoid yagging. Maybe it rotated after the yag. That's possible.
Yeah.
That is entirely possible. Another reason, again, for residents and fellows, make your yag opening small. Number one, it helps in the future if you had to do anything for IOLs. But number two, you don't have to make it huge. The visually significant PCO is the central 3 or 4 millimeters tops. So definitely make it smaller, way smaller than the optic. I prefer to make it 3 or 4 millimeters.
That's a great point. And I know both Sam and I, one of our great mentors, Dr. Hazeman, would probably echo that point. So I just always want to give him credit for all the great wisdom he's imparted to us.
I agree. Shout outs also to Dr. Turner, Anitra Turner. She's a great comprehensive and glaucoma surgeon. And just a taste of what we go through with training. Our first YAGs are one of the earliest things that we do when we're in residency, because it's a procedure that, generally somebody can not have a heart attack watching you do. That you can have a attending right there, watch you do it. And we all start from very humble beginnings. So I remember my first YAG probably took 5 minutes, right? And now a YAG takes 10 seconds. I mean, it's quick,
Yeah.
you know, I mean, you can do it efficiently for most people, which is a testament to how great the technology is. But shout out to Dr. Turner for watching me do like a
Yes.
5-minute YAG, just struggling through it. You know, it doesn't make a difference to the patient's outcome eventually, but it's much more comfortable for them to sit there for 10 seconds and have Dr. Koushik do it than have me do it 5 years ago and take 5 minutes.
I think my first one was 7 minutes, Sam. So
Yeah.
you got me beat even on the first one. Yeah.
But we do owe so
that's
much
great.
to our training. I mean, right? We had such good mentors. We all
100%.
start from nothing. Nobody's done eye surgery when they're born.
Yeah.
Except maybe Nathan Haseman. Dr. Haseman might have been born knowing how to do cataract surgery. Yeah.
Yeah. He is phenomenal. So yeah he might be.
It's so cool. I mean, you probably feel the same way about like Bill Wiley and the same way I feel about John Solomon. All these guys, they're such good mentors, such good surgeons, really inspiring, you know, and I'd love to just real quickly just hear about AECOS, because that's kind of one of those meetings those, you know, folks go to and kind of push the field forward in cooperation with industry.
Yeah, AECOS is a fantastic meeting. I was very honored to be able to attend this summer symposium at Deer Valley, Utah. I think it just brings together a lot of surgeons together in one room who are able to share their experiences with different technologies. But more importantly, it's a safe space, I think, where surgeons can share tricky cases, ways things could have been handled better. And I think that incredibly valuable, not only for other ophthalmologists in the room, but also for the patients who get to benefit from having their surgeon learn from someone else and the trials that they've been through. So it's a great meeting. Plus, you get to have a lot of fun in a beautiful location. So I would definitely go again, and I'm very happy that I got the opportunity to go.
I couldn't say it better myself. I mean, I think it really benefits patients in the end to have all of us kind of working together through difficult cases and through new technology, you know, adapting new techniques. All these things are things that we discuss. And like you said, in a very safe forum, which is awesome. You know, that case that I just showed the video of, I called you about. I don't know if you remember that. It was a few weeks ago. I called you. I was like, what would you do for this patient? And that's the sort of thing you do at AECOS is like bounce those cases off people, talk about it very briefly. I don't know if I mentioned he, you know, is kind of a very technical guy. He's an engineer, very, you know, understood it extremely well. And I was able to have the discussion with him as well that I had with you. So we had backup options. If we couldn't rotate that toric because of the YAG or because of zonular instability, you know, we had options that I think would have served him well, not as perfectly as just rotating the IOL. But again, if it just reminded me of an AECOS case to be like, you know, if I couldn't rotate that lens, maybe I'd put an LAL in the sulcus and just adjust the sills, you know, axis and magnitude based on that. And then my like backup plan was taking out the toric if there wasn't support for it and putting in 3-piece lens, either like in the sulcus with optic capture or as prep to do Yamani, so to do like an intrascleral haptic fixation, and then come back, regroup, and in the future do like I was going to leave him quite myopic so that we could do like a toric Evo ICL in the sulcus. So kind of all those things were things I think that were options for him. I'm super glad for him that we didn't have to do any of that, but it's fun to think about as a kind of theoretical practice.
Definitely. Yeah. And I'm glad that patient had you as their surgeon. They definitely looked out. That's awesome.